Assalamualaikum and good morning everyone. Today I would like to discuss with you why we need to study pharmacoeconomic and introduce some of the important tools in pharmacoeconomic that we use to assist decision makers. Now, we all want the best for everything. We want the best shirt, the best car, the best phone. In healthcare, we want to have the best doctor, the best medicine, the best vaccine, the best surgeon. But we all know as well that in the real world, we just don't have enough to satisfy what we want. We are unable to give the best doctor, the best medicine, the best vaccines to everyone. Because of our limited and scarce resources, we are forced to choose who to give, what to buy. In hospital, for example, every year, all the clinical departments will be requesting for increase in their budget to buy new equipments, new building, hire new staff. But because a hospital we only have a finite budget, such requests, if allowed, will result in sacrificing other department budget. So a hospital budget is like a cake. If you want to give a larger slice to another, for example, we want to give a larger slice to cardiology, it also means smaller slice to another. And often, this will result us in making a difficult choice, maybe sacrificing premature care or sacrificing geriatric service in order for us to increase budget for another clinical service. Scarcity forces us to choose, ration, and prioritize. And this is actually the most difficult problem that the decision makers have to face whenever they have to decide, because some of these decisions actually can result in perhaps loss of budget and death. How do we actually help decision makers to make these decisions? Leave it to the fate, toss a coin, leave it to the dice, or maybe like what this cartoon trying to tell us, sharing. Here they are telling Miss Jenkins that they are sharing, she is sharing the MRI scanning service with another patient to cut the cost by half. So regardless of these methods, many decision makers actually they want to try to rationalize the choice that they make. So some of them actually resorts to using a specific criteria. For example, here they often ask the criteria of can it work, the efficacy. Does the health procedure, service or programs do more good than harm to people who fully comply with the associated recommendation or treatment? So if we have two treatments here, one can allow patients to survive by 7 years, another one by 10 years, so we would say that B is more efficacious compared to A and should be chosen based on the criteria, can it work? Another criteria that also decision makers resort to, because they find perhaps an efficacy, because it is based from results of a controlled trial, it might not reflect the real world evidence. So they ask the questions of effectiveness. Does the procedure, service or program do more good than harm to those people to whom it is offered? And in the real world. So from this then, if again, the same examples again, okay, treatment B still provide a better and a more effective treatment compared to A, so the choice then would be B based on the criteria, does it work? So, but then, relying too much on this criteria, does it work, can be misleading. There was a study back in 1970s by a health economist that actually demonstrate why we shouldn't rely totally on this criteria when we make decisions. In that study, the researchers shows that there are evidence at that time that suggests 6 cancers out of 10,000 would not be identified. False negative if only one test was done. If 6 tests were done, the number of false negative would fall to 0.00003. Well, that's a very, very low number. Because of this, the American Cancer Society has endorsed a protocol of 6 sequential stool tests for cancer of the large bowel. So the pictures that I show, of course, is just for illustrative purpose, and it's not the real stool test that was done to detect cancer of the large bowel. Pointed out by the American Cancer Society, by this study, the American Cancer Society revised their decisions that the test should only be done to those with high risk patients. So, because of this then as well, okay, so they realized that relying too much on the evidence of efficacy and effectiveness would make them, would be misleading, because they would not be able to see the costs as a result of the decisions being made. So then a new criteria has been introduced by some of the decision maker. Is it reaching those who need it? So they are looking at the availability or accessibility in terms of the price that they can afford. Okay. So then we see that the price, if for example A and B here, A is cheaper than B, so we usually, the decision makers usually opt for A because it's cheaper. But then again, if we rely on price, it can be misleading. Because if we rely on price alone, we might forget other costs that can occur because of the decision that we make. For example, even though A is cheaper than B, so it may be also that the side effect, the adverse drug reaction from taking A is a lot more compared to B, which results in the cost of ADR much more higher compared to treating the ADR because of B. So, with this then, we realize that relying on efficacy alone, price alone, or cost alone is not sufficient for us to make an informed and rational decision making. We look here at drug A and B again. Even though drug A is less effective than drug B, but because it's cheaper and because the drug treatment is also the ADR treatment is higher compared to drug B, so we need to make sure that the decision that we make does reflect what actually the best for the society. So for this reason then, okay, a lot of the decision makers rely on pharmacoeconomic to help them come up with the best decisions to make this choice. Economic evaluations is one of pharmacoeconomic tools that has been used by decision makers to inform them in terms of the cost and consequence comparison between these alternative program and treatment. The economic evaluations allow decision makers to arrive with a decisions that give them the best benefit at the lowest cost, the greatest benefit for a expenditure. Economic evaluation is, by definition, is the comparative analysis of alternative courses of actions in terms of both their costs and consequences. In any economic evaluations, there are 4 basic tasks that they have to do. First is to identify, second is to measure, third is to value, and finally to compare the costs and consequences of the alternative being considered. The economic evaluations, there are 3 types of economic evaluations. Okay? So if they fulfill the criteria of first, that they are comparing both input and output or the costs and consequences of the alternative examines. And second criteria is that they are comparing at least two alternatives. If they fulfill these two criteria, then they are a full economic evaluations which can fall either in these three types: cost effectiveness analysis, cost utility analysis, or cost benefit analysis. In a nutshell, the difference between them is in terms of how they treat the benefit unit. CBA, the benefit unit is in monetary form. CEA, cost effectiveness analysis, the benefit unit is in the natural form. And cost utility analysis, the benefit unit is in the quality adjusted life year. Now, these are some examples of studies that utilize cost effectiveness analysis when they try to inform decision makers of the right choice. In this case, then, the alternative that they are investigating is regarding home-based medication review in older people. Is it a cost effectiveness? Is it a cost-effective option compared if we do not have home-based medication review? Now, home-based medication review is a service by a pharmacist, by the pharmacy, where they will visit the high-risk group in order to review the medication that they take at home and advise them on any potential pharmaceutical problem that they would have with the medicine. So in this study that they have, they are looking at geriatric patients, patients with more than 80 years old that are returning home from emergency admissions to hospital with at least 2 discharge drugs. So what happened is that they have here the alternative that they are considered. They are comparing between one, those who are receiving home medication-based review. This is the intervention group. So they would receive 2 home visits by a pharmacist within 2 and 8 weeks of discharge. So the pharmacists, when they visit the patients, they will educate the patients and also the carer, remove expired drug, inform the GPs if there are any drug reactions or potential interactions, and also inform the local pharmacists if an adherent aid was needed. In the control group, they only receive usual care without this home-based medication review. So the study actually followed the patients for 6 months to observe the outcomes. What they found is that the average total cost for the intervention, the home-based medication review, is £1,695 compared to the average cost to run without this home-based medication review is £1,424. So if we look into in terms of survival, so remember that they only follow the patients for 6 months, or in other words, it's 0.5 year. Okay. So what they found is that the HMR give a slightly longer survival compared to those in control, 0.4689 year compared to control, which is only 0.4618. When they adjust this value of survival with quality of life, it results in the quality adjusted life years of 0.0494 compared to 0.0569 in the control group. With this, then, they can actually calculate the incremental cost effectiveness ratio, the additional cost, to give the extra benefit compared to the other alternative. So here, what they found is that they need to pay $30,541 per additional life years compared to those in the control group. So, and also they found that they need to pay $54,454 per additional quality adjusted life years that they want to gain compared to those without the home-based medication review. So this is one examples of the usual graph that you would see in a cost-effectiveness study, which is what we call as a cost-effectiveness plane. So in this cost-effectiveness plane, they actually see that the intervention, okay, after many simulations would result in the conclusions that HMR would be more expensive but also more effective, and that most of the time it will be above the cost effectiveness threshold by the decision makers of 30,000. So with this then, they shows that home-based medication review, okay, only have 25% probability of being cost effective. So this 25% probability is quite low, and because of this then, at that point of time, the paper actually conclude that home-based medication review is not a cost-effective service. Even though it's good, okay, but it's not cost-effective because there's only a small, non-significant gain in quality of life. There's no reduction in hospital admissions, and it also has a low probability of cost effectiveness. They suggest that the policy of home-based medication review then need to be reviewed. So there are, of course, many studies out there that use pharmacoeconomic, economic evaluations to try to inform decision makers on many other healthcare problems. For example, here this was study which was done to compare the cost effectiveness between methadone treatment and long-term rehabilitation treatment. In other words, formulation certainty for opioid dependent. So another study that was done, okay, was in Malaysia when they tried to look into a choice problem, okay, is when they use the economic evaluations to study the choice of a policy change. In other words, dispensing separations in Malaysia. So dispensing separations is one of the most contended healthcare issues in Malaysia. There are so many arguments on this on paper by all parties, okay? But there is no concrete actions being taken. Okay? So one study have looked into employing economic evaluations, in this case cost-benefit analysis, where they try to simulate the cost effectiveness of dispensing separation by looking at whether the dispensing prescription by the pharmacist or doctor can result in different costs and benefit. By looking at the medication error, the adverse drug reactions, and productivity losses that can incur either of these choices. What it shows is that the net monetary benefit, okay, with a pharmacist dispensing for per prescriptions is 355 ringgit for hypertension, 345 ringgit for diabetes, 437 ringgit for dyslipidemia. Or in other words, dispensing by pharmacists would give a net monetary benefit, is cost-effective for Malaysia. This is again another examples where cost-effectiveness analysis being used in Malaysia. So in this case, it's being used to actually look into the long-term economic benefits of improving glycemic control in Malaysia. So this study actually simulates the effect of glycemic control across many of the micro and macrovascular complications of diabetes to actually give us the conclusions about what can we expect in terms of economic benefit if we manage to improve glycemic control in Malaysia. In this study, it was found that 1% reduction in HbA1c was associated with reduced cost of treating diabetes complication and increase in life expectancy. So this is quite a lot. And actually, it is one of the important evidence out there to show the benefit of targeting HbA1c in treating. So what I have been showing through these examples for the past few minutes is to show you all the potential issues and choice problem that we can analyze using pharmacoeconomic, or in this case here, cost effectiveness analysis, economic evaluation. But as we have discussed, or perhaps some of you know here, economic evaluation is only one of the tools of pharmacoeconomic. Pharmacoeconomic itself is a small subdiscipline of economic. Economic evaluations is a tool of pharmacoeconomic, and cost effectiveness analysis, cost benefit analysis, cost utility analysis is one of the types of analysis in economic evaluations that we can use to analyze problem. Now, all of these choice problem, when we analyze and when we generate the evidence of pharmacoeconomic, allow us to help decision makers to come up with the decisions of what is the best choice to make. In fact, when the decision makers try to come up with a choice, there is actually a whole discipline that is being dedicated to actually analyze this problem. And this is what we call as health technology assessment, or in short abbreviated as HTA. Health technology assessment is a discipline that employ various tools to actually help them come up with the decisions. So, usually, for example, in Malaysia, we look into the evidence of safety, we look into the evidence of efficacy, we look into the evidence of quality before we can make a choice whether the drug can be registered. But when we want to make a decisions whether it should be included in the formulary, whether the Ministry of Health should actually give funding to buy that treatment for Ministry of Health facilities, we usually add another 2 additional criteria. Criteria of efficiency, which is actually can be analyzed using economic evaluation, cost effectiveness analysis, cost utility analysis, or cost benefit analysis. And another evidence that is also frequently being used, and in the case of Malaysia is mandatory, is affordability. And in this case here, the criteria of affordability can be investigated with budget analysis. Throughout the world, pharmacoeconomic is increasingly used for decision making. So you have here across the 5 continents in the world: Africa, Latin America, North America, Asia, Europe, Oceania. So many of them nowadays rely on pharmacoeconomic, either economic evaluations or budget impact analysis, or even both, to help them decide either for regulatory purpose or for reimbursement purpose. In Malaysia, pharmacoeconomic is very much welcome, and at some extent has been made mandatory in the regulatory and also reimbursement for treatment in Malaysia. But the pharmacoeconomic evidence that we have, unfortunately, are limited. Because number one, we usually have lack of quality local evidence. We do not have much evidence of epidemiology, especially. We do not have incidence, the prevalence of some of important disease, or perhaps the longitudinal data of the change that can happen when patients experience the disease. We also have perhaps a lack of legal support. In some countries, whenever there have been a challenge in the court when the healthcare authority decided that they don't want to purchase drug A because it's not cost effective. So there have been instances where the patient group, okay, actually sued and pursued legal actions against the health authority because they say that why do you actually use dollar to make decisions on the life of their child? It's a very difficult case, okay? But because there is a clear legislation out there in that country that protect the decision by the health authority based on this cost effectiveness, then they do not have a major issues because of these decisions. But in Malaysia, we might have a problem if the legislation does not support the decision using pharmacoeconomic evidence. We also have a problem of inadequate capacity. We do not have many experts in Malaysia who are competent to conduct or interpret pharmacoeconomic evidence. And also, evidence and efficiency is also sometimes not always the priority for decision makers. So sometimes you might have invest a lot to conduct a study, okay, to generate pharmacoeconomic evidence to show that your drug is cost effective, is really affordable, and provide really a good financial impact to the institutions. But sometimes decision makers might just put your evidence aside, put your argument aside, and just tell you that, well, we already decided this, you do not need to know the reasons, we have our own reason, which we cannot disclose, and that's it. So that is actually the challenge that we have when we try to use and pursue economic evidence in Malaysia. But in any case, okay, the role of pharmacoeconomic is always only to inform the decision makers. So pharmacoeconomic allow decision makers to be more transparent in their decision, okay, to actually outline clearly what is the cost and consequence of each actions and what will be the impact, financial, social, or health impact in each of their decisions. So even though the final decisions would come to will only be by the decision makers alone, perhaps, okay, but the role of pharmacoeconomic is really, really critical to help the decision makers arrive at their decisions. With that, I hope you understand and appreciate the importance of pharmacoeconomic in helping the decision makers. And I look forward to discuss further these pharmacoeconomic tools with you, either economic evaluations or budget impact analysis. Thank you and Assalamualaikum.